Imagine for a second, right, that you are investing a significant amount of your time, your energy, and frankly, a lot of your money into a cutting-edge regenerative therapy.
Yeah, it's a massive commitment for anyone to make.
Exactly. I mean, we're talking about using your body's own blood to heal itself. You go to the clinic, you go through the whole procedure, you wait for the results, and, well, nothing happens.
Right, the tissue just doesn't regenerate. The symptoms don't improve at all.
Yeah, and the kicker here, the culprit isn't the doctor, and it isn't a failure of the technology. It's actually a completely normal, over-the-counter pill sitting in your medicine cabinet right now.
Oh, absolutely.
And it's secretly sabotaging the entire biological process.
It is, it's a uniquely frustrating scenario. You are trying to harness your body's raw, natural healing power, but modern pharmaceuticals, the things we just take every single day without a second thought, they are fundamentally designed to silence those exact same biological signals. Like, we rely on those drugs to function comfortably, I get it, but they alter our cellular environment in ways that can render regenerative treatment just completely useless.
Which brings us directly to the heart of what we are unpacking today for you. We are looking at this wild intersection of everyday pharmacology and the O-shot.
It's such a crucial topic.
For context, our sources outline the O-shot as a procedure utilizing platelet-rich plasma, or PRP for short, and it's injected directly into vaginal tissue.
Right, and it's being used for some really complex issues, sexual dysfunction, stress urinary incontinence, and lichen sclerosis, which is this chronic inflammatory skin condition.
Yeah, and the appeal is obvious. I mean, you are using your own blood, so allergic reactions are essentially a non-issue. And the results unfold over about 3 months, potentially lasting up to like 18 months.
And this is the big what. But that timeline and really the success of the treatment itself hinges on a very fragile microscopic event. The O-shot extracts platelets from your blood, concentrates them, and re-injects them. Those platelets then have to perform a highly specific mechanical function.
So if your daily medications disrupt that function, the procedure basically fails.
Exactly.
So we have a very specific, high-stakes question driving this deep dive today. Can systemic antihistamine or corticosteroid use in the days prior to an O-shot suppress platelet alpha-granule degranulation?
To really answer that, we have to isolate what actually happens to a platelet during a PRP procedure.
Walk us through it.
Well, our sources covering allergic asthma actually provide a fantastic breakdown of platelet anatomy. Under normal physiological conditions, resting platelets just circulate in your bloodstream in a discoid shape.
Just kind of floating along.
Yeah, exactly. They are smooth, quiet little discs just flowing with the current. But when they are activated, either by a natural injury or, by the mechanical injection of the O-shot, they undergo this radical physical transformation.
Okay.
A specific receptor on their surface called integrin alpha I beta 3 undergoes a conformational change.
Wait, let me stop you right there. A conformational change? You mean the platelet physically shapeshifts to lock onto other things?
Yeah, that is the physical reality of it. The protein structure of that receptor literally folds into a new shape.
Oh, wow.
And this new shape gains a remarkably high affinity for its ligand, which is essentially the chemical key that fits into this newly formed lock.
Right, right.
Once that lock and key connect, the platelets can suddenly stick to the tissue and to each other. They clump together.
But the clumping is just step one, right?
Exactly.
Yeah.
The aggregation is only step one. The critical step for regenerative medicine is what happens next. Exocytosis, or what we call degranulation.
Okay, let's unpack this, because degranulation is the term that keeps popping up in all these studies.
Right, so inside these platelets, there are 3 main types of secretory granules. You have dense granules, lysosomes, and alpha granules.
And the alpha ones are the VIPs here.
Oh, totally. While they all play a role, the alpha granules are the heavy lifters for tissue regeneration. They are packed with massive amounts of active substances, specifically growth factors like platelet factor 4, beta thromboglobulin, and thrombospondin 1.
That's a mouthful.
It is. But when the platelet degranulates, the membrane of those alpha granules fuses with the platelet's outer membrane, and it forcefully expels all those growth factors into the surrounding tissue.
So if you're looking for a way to visualize this, think of these resting platelets as tiny molecular piñatas circulating in your blood.
I love that analogy.
Right. And the O-shot is basically a process of gathering all these piñatas into one highly concentrated area. But if those piñatas don't break open, if they don't actually degranulate, you don't get the candy.
No candy for you.
Exactly. And the candy in this scenario is the cocktail of growth factors that your body absolutely needs to build new blood vessels and regenerate that damaged tissue.
The visual holds up really well because it emphasizes the mechanical necessity of the whole process. I mean, if the shell doesn't break, the contents are completely useless no matter how many platelets you inject.
Right.
So the core issue we need to unravel is whether the medications you took that morning somehow reinforce the shell of that piñata, making it impossible to burst open upon injection.
Okay, so let's start with the most common suspect. Allergy season hits, you grab an antihistamine. We know antihistamines stop allergic reactions, which involves stopping the degranulation of mast cells, which release histamine.
Right, that's their whole job.
So the logical leap here is, if an antihistamine stops mast cells from degranulating, does it also stop platelet degranulation?
It's a fair assumption. We can actually trace the answer to that back to a foundational 1973 study that specifically examined antihistamines and platelet aggregation.
1973, wow.
Yeah, old but gold. The data provides a very clear distinction between what happens in a lab and what happens in a human body. When researchers looked at normal volunteers taking standard, therapeutic doses of antihistamines in vivo, meaning circulating in a living person platelet aggregation, was entirely unimpaired.
Meaning the platelets were still clumping together and functioning totally normally.
They were. The researchers could only force antihistamines to inhibit platelet clumping in vitro in an isolated test tube, and even then they had to introduce massive, non-physiological concentrations of the drug directly to the blood.
Oh, I see.
Yeah, we are talking about toxic levels you could never safely achieve by just swallowing a pill.
But wait, we have to push back on this based on some of the other clinical data we have.
Oh, for it.
Our sources on chronic spontaneous urticaria, which is essentially chronic hives state, explicitly that certain antihistamines, like ripatidine, specifically inhibit PAF-induced degranulation. And PAF literally stands for platelet activating factor. I assumed that if a drug blocks something literally called platelet activating factor, it has to be shutting down the platelets. I mean, it's right there in the name.
Oh, no, I know. It is a perfect example of how biological naming conventions can lead you down the completely wrong path.
Right.
You are entirely correct that PAF is platelet activating factor. It's a highly potent bioactive phospholipid, and it earned that name upon its discovery in 1974 because researchers observed it inducing platelet aggregation.
Okay, so where's the catch?
The complication is that biology is incredibly thrifty. A single molecule like PAF doesn't just act on one single type of cell. PAF also binds to receptors on various immune cells.
Oh, so just because it's called platelet activating factor doesn't mean it only communicates with platelets?
Yeah.
It's talking to other cells too.
Exactly, including mast cells, which are the primary drivers of hives. The studies looking at ripatidine and levocerazine demonstrated that these antihistamines successfully inhibited PAF-induced degranulation, specifically in cultured LAD2 mast cells. They were not looking at platelets. The antihistamine operates by blocking the H1 receptor and interfering with the PAF receptor on the mast cell, preventing the release of histamine. It is not circulating through your bloodstream, putting a chemical lock on your platelets.
Let me make sure I'm following the mechanics here for the listener.
Sure.
If you take a standard over-the-counter antihistamine, the drug is actively hunting for mast cells to silence the histamine response. But it's essentially ignoring the platelets.
Pretty much.
It's basically walking right past them, so your seasonal allergy pill isn't going to ruin your O shot.
Based on the synthesized literature, that is the consensus. Systemic antihistamines at normal therapeutic doses do not appear to suppress the alpha-granule degranulation we need for PRP. They just act on completely different cellular pathways.
Okay, that clears up the antihistamine question. That's a relief.
Definitely.
But if those are mostly in the clear, we need to move up to the heavier artillery in the medicine cabinet corticosteroids, things like prednisone or dexamethasone.
Right, the heavy hitters.
We know these aren't just blocking a single receptor on a mast cell. These drugs rewrite inflammatory pathways at a genomic level. So how do they impact the platelets?
Well, corticosteroids are undeniably powerful because they operate through both genomic and non-genomic pathways mediated by glucocorticoid receptors. In terms of the genomic impact, they rapidly suppress inflammation by transrepressing transcription factors like NF-kappa B and AP1.
Okay, you'll have to unpack transrepressing transcription factors for me. What are they actually doing inside the cell's command center?
Right, sorry. A transcription factor is essentially a protein that reads the DNA and tells the cell which genes to turn on or off.
Got it.
NF-kappa B and AP1 are the specific transcription factors that act as the master switches for inflammation. When a corticosteroid enters the cell, it represses them. It binds to them and physically blocks them from turning on the inflammatory genes.
And because platelet activation is, at its core, an inflammatory cascade, shutting down that master switch has profound effects on how platelets behave. And to see that in action, we have this really interesting study from veterinary medicine.
We do, yeah. The source examines dogs with hyperadrenocorticism, which is a condition characterized by the body naturally producing excessive amounts of cortisol.
Okay.
The researchers administered prednisolone, a common glucocorticoid, to see its direct effect on platelet function. The findings were pretty stark.
What did they find?
The prednisolone suppressed both platelet aggregation and secretion. More specifically, it suppressed the secretion pathway that relies on the generation of thromboxane A2, or TXA2.
Why is thromboxane A2 so important to this specific process?
Think of TXA2 as the biological amplifier. When a few platelets get activated, they produce TXA2 to recruit all the other nearby platelets to join the effort and degranulate.
So it's like a call to arms.
Exactly. If you suppress TXA2 generation, you kill the signal. The platelets might be present, but they are functionally muted.
So prednisolone acts like a chemical straitjacket. It stops the TXA2 signal, which means the platelets can't amplify the reaction and they don't release their growth factors.
Right.
But, and here's where it gets really interesting, we have that dog study saying steroids suppress platelet function. But then we have a totally different study on mice showing that dexamethasone, another corticosteroid, actually increased platelet production.
Yes.
The researchers gave mice dexamethasone, their overall platelet counts shot up, and their bleeding times went down. How can a steroid chemically straitjacket platelets in one study, but seemingly boost them in another?
It's a brilliant paradox, honestly, and it forces us to separate two distinct biological concepts, the sheer creation of platelets versus the mechanical function of those platelets.
Walk me through what happened in the mouse study.
So the researchers found that dexamethasone acts on megakaryocytes. Megakaryocytes are the massive cells living in your bone marrow that serve as the factories responsible for manufacturing platelets.
Okay, the factories.
Right. The steroid entered these factory cells and upregulated a specific gene known as the GITA gene. By turning this gene on, it hyperstimulated a process called proplatelet formation.
So the steroid essentially walked into the bone marrow factory and turned all the machines up to maximum speed.
Yep. It flooded the bloodstream with a massive number of young reticulated platelets. That is why the overall blood test showed a higher platelet count and why the initial bleeding time decreased.
Ah, I see.
The sheer volume of new platelets temporarily compensated for the fact that each individual platelet was chemically impaired.
Oh, I see the paradox now. You have this massive new army of platelets, but they're all still wearing that chemical straitjacket. You have more soldiers, but their weapons have been confiscated.
That is an excellent way to conceptualize it. And this brings us back to the practical reality of the O-shot.
Right.
When you go into the clinic, they are extracting a set, finite volume of blood. You need the specific platelets within that single tube of blood to be incredibly reactive. You need them to degranulate fully and instantly upon being injected into the vaginal tissue.
But if you're full of dexamethasone or prednisone, you might have a high platelet count in that tube, but when the doctor injects them, they just sit there. The TXA2 pathway is suppressed. They can't signal each other to release the growth factors.
The clinical takeaway is that recent systemic corticosteroid use, theoretically and very likely practically, blunts the efficacy of the O-shot's activation phase.
Wow.
Yeah, so if someone is managing a severe flare-up of lichen sclerosis, which frequently requires potent steroids to control the inflammation, the timing of the PRP therapy becomes a critical variable.
Right. You can't be heavily suppressed by systemic steroids the week you go in for a regenerative treatment and expect maximum results. It completely defeats the entire purpose of harnessing your body's uninhibited healing response.
The physiological mechanisms strongly suggest corticosteroids present a genuine risk to PRP efficacy. Their use just needs to be carefully coordinated with a physician to ensure the platelets have regained full functional capacity before the blood draw.
Okay, so if corticosteroids are this complex boosting sheer numbers while simultaneously killing function, it naturally makes you wonder about the more blunt force tools we use every single day.
Oh, absolutely.
You know, the things you grab for a headache or a tweaked knee. Are everyday painkillers just as confusing? Or are they straightforward in how they affect platelets?
They are brutally straightforward. And for this, we don't have to rely on theoretical mechanisms. We have a massive, definitive systematic review that evaluated 792 patients to establish rigid guidelines on which medications must be ceased prior to PRP injections.
So if someone is looking at their medicine cabinet right now, what is on the absolute do not take list?
The primary proven saboteurs are aspirin, acetaminophen, though the data notes acetaminophen is destructive in a dose-dependent manner, and non-selective NSAIDs.
By non-selective NSAIDs, we are talking about your standard over-the-counter ibuprofen, naproxen, and prescription drugs like diclofenac.
Yes, exactly. These medications are highly destructive to platelet aggregation.
How destructive?
Well, the review highlighted specific clinical data to demonstrate the severity. In one study, a single intravenous infusion of diclofenac caused a patient's thromboxane B2 levels to plummet to just 1.6% of their baseline.
Wait, 1.6% of baseline? How does diclofenac literally cause that massive of a drop? What is it actually breaking inside the platelet?
It all comes down to an enzyme called cyclooxygenase, or COX. Non-selective NSAIDs block the COX-1 enzyme.
Yeah.
The COX-1 enzyme is the literal engine that a platelet uses to produce thromboxane. If you block COX-1, the platelet cannot synthesize the chemicals it needs to aggregate. It flatlines their communication.
Wow.
In another study examining patients recovering from orthopedic surgeries, they tested the platelets of individuals who were actively taking NSAIDs. Their platelets demonstrated a dismal 2.2% aggregation rate.
2.2%.
Compared to the control group, who were not on NSAIDs, their platelets successfully aggregated at an 80% rate.
Going from 80% down to 2% just because you took an ibuprofen, that is staggering.
It really is.
It's like throwing a heavy wet blanket over a fire. You are paying thousands of dollars for a regenerative therapy designed to utilize your platelets, and taking an NSAI ensures your cellular machinery is literally disabled.
It is a biological certainty, and the duration of that disability varies by the drug too. Aspirin, for example, permanently and irreversibly binds to the COX-1 enzyme in the platelet.
Permanently?
Yes. Because platelets don't have nuclei, they can't synthesize new enzymes. That means aspirin disables that specific platelet for its entire lifespan, which is roughly 7 to 10 days.
So if you take an aspirin, those specific platelets are permanently broken until your body naturally replaces them a week later.
Correct. NSAIDs like ibuprofen bind reversibly, so the block isn't permanent, but the suppression is profound while the active drug remains in your system.
That makes sense.
To access the growth factors in the alpha granules, you must strictly abstain from these drugs prior to the blood draw.
But reading through this systematic review, there's a very interesting caveat. There's actually a safe list for people who might desperately need pain relief leading up to their procedure.
There is, and it highlights why understanding the precise mechanism of a drug is so important. COX-2 selective NSAIDs and statins do not significantly hinder platelet clumping.
Let's dissect that. Why is ibuprofen the ultimate enemy of a platelet, but a COX-2 inhibitor, something like celecoxib, often sold as Celebrex considered safe?
It loops back to the COX enzymes. We established that non-selective NSAIDs blindly hit both COX-1 and COX-2 enzymes.
Right.
COX-1 is the internal communication network for the platelet. It is non-negotiable for thrombosis and activation. COX-2, however, is a different pathway entirely. COX-2 primarily targets the inflammation cascade happening out in the surrounding tissue, usually in response to pain or injury.
So if I'm piecing this together,
Yeah.
if COX-1 is the internal phone lines inside the platelet's headquarters, COX-2 is like the local PA system out on the streets where the injury actually happened.
That is a highly accurate way to separate their functions. A COX-2 selective drug only cuts the wires to the street PA system. It bypasses the platelet's internal headquarters entirely. Because it leaves the COX-1 enzyme untouched, the platelet retains its full, uninhibited ability to aggregate and degranulate.
Which means the alpha granules can still release their growth factors.
Exactly. And the same logic applies to statins, which are widely taken for cholesterol management. The systematic review concluded they operate on pathways that do not warrant suspension before a PRP injection.
Okay, we've ventured through a lot of complex cellular biology today. We've gone from the bone marrow factories producing megakaryocytes down to the shape-shifting receptors on a single platelet. So let's pull all these threads together and answer the core question of this deep dive. So what does this all mean?
Well, the mission was to determine if systemic antihistamines or corticosteroids suppress platelet alpha granule degranulation prior to an O shot.
Right.
The evidence points to two distinct answers. First, systemic antihistamines taken at normal. Everyday doses do not suppress this process. They actively target mast cells to prevent histamine release, leaving your platelets completely intact and functional.
Second, corticosteroids are a documented risk.
Hmm.
Even if a drug like dexamethasone increases your overall platelet count by stimulating your bone marrow, it simultaneously suppresses the crucial thromboxane-mediated secretion pathways. It puts a chemical straitjacket on the platelets you need for regeneration. Their use must be managed carefully.
And finally, the non-selective NSAIDs, ibuprofen, naproxen, and aspirin, are guaranteed saboteurs. They aggressively shut down the Kix1 enzyme, reducing platelet aggregation to near zero. They are strictly prohibited if you want a successful PRP outcome.
When you really map out how these drugs operate, it fundamentally changes how you view your medicine cabinet.
It really does.
We reach for these pills so casually to get through the day, completely unaware that beneath the surface, they are rewriting how our cells were allowed to communicate.
It reveals a fascinating tension in modern medicine, I think. For the entire 20th century, pharmaceutical science was largely dedicated to engineering highly effective off-switches.
Yeah.
We spent billions developing drugs to forcibly silence our body's natural symptoms. We blocked the inflammation. We suppressed the immune response. We cut the chemical wires that transmit pain.
And now we are pivoting to regenerative therapies, like the O-shot, which demand the exact opposite. We actually need the inflammatory cascade to trigger the healing process. We need the platelets to sound the alarm.
It suggests a profound shift in how we might view treatment in the coming decades. In the future of regenerative medicine, the ultimate key to healing may be less about discovering which new, complex synthetic drugs we can invent, and much more about mastering the discipline of knowing which daily medications we need to temporarily remove, just to get out of the way and let our own biology do its job.
You spend all that money to unleash your body's healing potential. You really need to make sure you didn't accidentally chemically lock the door on your way to the clinic. Thanks for taking this deep dive with us today. See you next time.